Now, here's your host.
Hello, everybody, and welcome to Public Report. My name is Rick Brooks, and it's a joy to be here with you today. We're going to talk to a doctor today that's very much specializing in neck surgery. He's going to talk to us about the thyroid gland. His name is Robert Leinbach. God bless you, and welcome to the program today, Dr. Leinbach.
It's my pleasure.
Good to have you with us. We're going to talk about the thyroid gland, and most people out there probably have no idea as to what the thyroid gland does. How does it operate? Talk to us about that.
Well, the thyroid gland is a butterfly-shaped gland in the neck. It's in the lower portion of the neck. It lies just below the voice box and just in front of the trachea, which is the windpipe.
Okay.
The cells in the thyroid gland are able to take up iodine, and they produce a hormone called thyroid hormone. And that hormone circulates through the body and helps our body's metabolism, which is basically the production of energy.
Okay. Now, we've heard this term called thyroid nodules. Would you explain that to us a little bit?
Well, occasionally nodules will form in the thyroid. Nodular disease of the thyroid is quite common. In the United States this year, close to 300,000 new thyroid nodules will be discovered.
Wow.
Depending on how you look for the nodules, the incidence in the general population is between 5 and 40%. In studies where they simply felt the neck and felt a lump, the incidence is about 5 to 10%. If the studies went further and actually did a sonogram or an ultrasound of the neck, the incidence is between 20 and 40%. So they are very common.
Okay, so now how are these thyroid nodules usually detected? Is it just by somebody reaching up here and they're shaving and all of a sudden, well, wait a minute, what is that? Or do they have to go to the doctor and have a sonogram, as you mentioned? How are they found?
Well, typically patients are fairly asymptomatic with a thyroid nodule. They may not know that they have a nodule. And so they're usually picked up by their primary care physician during their annual examination, where the physician may feel a lump in the lower neck. And then the physician may send the patient for an ultrasound, which will define a nodule. It'll tell you whether it's cystic or solid, or whether there's any suspicious findings like calcifications in the nodule. Nodules can be picked up incidentally. Say you go to the physician and you have a neck MRI scan or a CT scan of the chest, and it picks up a nodule that you may not know that you had, and then you need further workup after that.
Okay, now when we talk about age groups, doctor, are the younger people more susceptible to that, or do you have to wait till you get older for that to occur?
Well, nodules are more common in women. Thyroid cancer is more common in women. It typically presents itself in women between 30 and 50. If you find a nodule in a man or in an older patient, you are more suspicious that it may be a malignancy. So you have to be quite careful.
Sure. Now for the average person that's sort of standing at home right now watching this program, and they're all of a sudden rubbing their neck and looking in the mirror, should they be really aware as they might be in this danger with this thyroid nodule, or is there something that can be done about it right away?
Well, the good news is with thyroid nodules, the majority of nodules are benign. Ultimately, only 5 to 10% are found to be cancerous or malignant. So you always have to discuss that with the patient. When a patient is referred to my office with a thyroid nodule, the critical question that they would like answered is this nodule cancerous?
Yes.
Is it malignant?
Right.
And so there's a whole series of steps to work that up.
Well, let's talk about that, because that's probably the number one question is, if I do have a nodule, how are we going to determine that it is cancerous or it's not?
Well, the first thing you do in the office encounter is you take a history. So thyroid cancer tends to run in families. So you always want to ask, did mom or dad or grandmother have thyroid cancer? Has anybody in your family had surgery on the thyroid? A history of radiation therapy. If you've had radiation therapy to the neck, it's going to increase the risk of thyroid cancer. And then you want to ask about symptoms. Just to review the anatomy, the thyroid sits over the trachea, and there's some important nerves that run up to the vocal cords that help the vocal cords move. So if you have a large thyroid that's compressing a nerve, or you have a tumor possibly that's invaded a nerve and damaged a nerve,
Right.
you could present with hoarseness, a voice change. You ask about trouble swallowing. If you have a large thyroid gland in your lower neck, it can compress the esophagus, which is the muscular swallowing tube that connects the throat to the stomach. So, and then of course you want to feel the nodule. Is it fixed? Is it firm, or is it soft and mobile? How large is it? Nodules over 4 centimeters are more likely to be cancerous.
Okay, and what about those that smoke or use tobacco in any form? Does that increase the nodule potential?
No, smoking and using tobacco doesn't affect nodules.
Okay, but we're certainly not advocating and promoting that we should do that, right, doctor?
Right. Yeah, I still tell every patient to not smoke. That's good advice.
Now, let's just walk through this scenario, because probably somebody's out there watching the program now and they're saying, oh my gosh, I feel like I'm a candidate. I think I need to go to the doctor. Suppose someone was diagnosed and their nodules were cancerous. Would you take us through step by step as they come into the office, what's going to happen to that individual to finally get them cured?
Sure. Well, a patient will come in. Typically, they may have already had an ultrasound. So we can go over that. Usually they've had thyroid function tests performed, which is a blood test called TSH. And the majority of patients with nodules are going to have normal thyroid function.
Okay.
The most important diagnostic test to determine where to go is called a fine needle aspiration of the thyroid nodule. So it's an easy test. We do it in the clinic. If the nodule's large enough and you can feel it, you can numb the skin overlying the nodule and introduce a fine 23 gauge needle into the nodule, aspirate some cells, and send them to a pathologist. And we have excellent cytopathologists in this area. And what they do is they typically give you 4 reports. They say these cells look cancerous. So that's easy. That patient needs to go to the operating room to have surgery. They can say these cells look benign. Maybe this is a colloid nodule. And those patients usually do not need surgery unless the nodule is very large, or unless the nodule is growing rapidly over time. They can say this is indeterminate, which means maybe you didn't give us a good enough sample to make a call. And then there can be a gray area where this could be benign or could be malignant. We see follicular cells, which are thyroid cells, and then we usually have a discussion with the patient about possibly proceeding with surgery, either removing part of the thyroid or the total thyroid.
Okay. Now, are there some names that maybe people could sort of, tune in and maybe you can throw some names out there if someone's thyroid is cancerous? Are there certain stages that it goes through?
Well, there's 4 types of thyroid cancer. There's papillary is by far the most common, with over 80% of cases. Follicular, there's about 15% of cases, and then anaplastic and medullary are very rare. So, like I said before, papillary cancer usually is more common in women. The treatment for thyroid cancer is surgical. Removal of the thyroid with a surgery called thyroidectomy. Depending on the size of the nodule and the extent of the disease, whether it's spread through outside the capsule of the thyroid, the age of the patient's important, the gender of the patient's important. Male patients tend to do worse.
Okay.
Patients may need to have adjuvant therapy after thyroidectomy, which would be radioactive iodine ablation. The thyroid cells are very interesting in that they're the only cells in the body that can take up iodine, and they use the iodine to make their hormone.
Okay.
So if you give a patient radioactive iodine after thyroidectomy, it will find the remnant thyroid tissue that may be left behind in the neck and seek it out, those cells will take it up and they will be destroyed.
So is there any medical treatment I mean, you've talked about surgery. What about medicines? Are there any medicines that will alleviate this problem?
No, thyroid cancer is treated surgically, and then quite a few patients elect to undergo the radioactive iodine therapy within the first 6 months following surgery.
Okay.
And then we typically follow these patients every 6 to 12 months after that.
So a patient who has any kind of signs of a nodule being in the throat area, it would be to their advantage to make sure they get to their doctor very quickly.
Right. Any neck mass is cancer until proven otherwise, really, in an adult. And like you said before, a smoking history is, we're not talking about squamous cell carcinoma, which is another type of head and neck cancer.
Right.
But smoking does increase your risk for head and neck cancer. So.
Okay. Well, doctor, if someone wants to get in touch with you, get in touch with your office, get more information on thyroid cancer and et cetera, how do they do that? Where do they go?
Well, they can go to the Cornerstone Healthcare website. I'm with Cornerstone, and my practice is High Point Ear, Nose, and Throat. They could call the office, which is 802-2085, and we'd be happy to see them and take care of them.
Okay. Well, I guess maybe we don't want moms and dads to panic, but we should. You are saying to us is that as human beings, we should be extremely aware of lumps and bulges and things around our neck, and not just sort of take that lackadaisically, but just say, you know what, we need to go to the doctor and make sure everything's okay.
Exactly, especially if the mass is increasing in size and it wasn't there 6 months ago.
Yes.
It'd be very important to have that evaluated.
Okay. Well, thank you, Dr. Leinbach, for being here with us today on the program. You've certainly given us a lot of information, and you've given us contacts and emails, our web address, and so people can get in touch with you and clear up that problem.
Hey, well, I appreciate it. Thank you for having me.
Thank you. Hey, don't go anywhere. We're coming up with another guest in just a moment.